You are listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I am your host, Selene Yeager. Each week, I bring you advice from athletes, scientists, researchers, and other experts to help you feel and perform your best, no matter what your hormones are doing. This show is a production of Live Feisty Media. Hello, strong, feisty women. I hope you all are well. So let's talk heart disease, specifically the health of our arteries. By now you've heard that your risk of heart disease can rise with menopause. As our estrogen levels decline, it can be harder to keep cholesterol in check, and women can see their LDL cholesterol, their triglyceride levels, and their blood pressure rise. I've also seen some very recent research specifically on coronary artery calcium, or CAC for short, which is essentially the amount of calcified plaque buildup in the arteries, which is an underlying cause of cardiovascular disease events like heart attack and stroke. Anyway, some researchers analyzed data from 579 postmenopausal women who were taking statins to control their cholesterol and who had also undergone 2 CAC scans at least 1 year apart. And what they found was, when compared to men of similar age, they found that among women with low to medium CAC scores to start with, their scores increased much faster than men. In fact, their CAC increase was about twice that seen in men. So, postmenopausal women also appear vulnerable to a faster rise in arterial plaques. And to make matters more confusing for menopausal women, the research on hormone therapy is also mixed here. I'm not going to get into all of these studies in this intro, it would be too long. I'll drop the studies in the show notes, however, in case people want to check it out. But suffice it to say that even very recent studies don't agree on the benefits and risks here. Though, if you do have a high risk for heart disease, medical societies do recommend taking what they call a risk stratified approach to hormone therapy, meaning the higher your risk, the more caution they recommend. And when it comes to risk analysis, the picture for women is also more complex. One 2024 study that just came out suggests that practitioners should take female-specific risk factors like high blood pressure during pregnancy into consideration, as well as CAC scores when calculating a woman's cardiovascular disease risk if there's any question when they're going into these conversations about hormone therapy for women. And all of this has just made me very curious. When I plug my own numbers into one of those online risk calculators, it comes back very low, like 1.2%. But we know, and have done past shows on this, that those calculators underestimate disease risk in women, especially younger women, and 50-year-old women are younger women in this scenario. So I dig a little deeper. I don't have any pregnancy-related risks. My blood pressure is generally under 120/80. My triglycerides are generally around 50 or lower. My HDL is usually around 100. But my LDL has always been borderline high, like in the 150s. And it shot up 30 points when I hit menopause. And though I've been able to bring that mostly back down, it's still borderline high. And my ApoB is normal, but also high normal. So what does it look like inside those arteries of mine? Out of personal and professional curiosity, I decided I'd get a coronary artery calcium scan, or a CCTA scan, just to see what it looked like in there now that I'm a few years post-menopause. And that led me to a special kind of CCTA scan from a company called Cleerly, which pairs your scan, your CCTA scan results, with machine intelligence to not just tell you if you have plaque and where it is and how much, but what type of plaque is in your heart's arteries. And that was super intriguing because though obviously we want to have the least amount of plaque in there as possible, there's a difference between stable plaque and unstable plaque, which we'll get into in detail in the conversation you're about to hear. So this is pretty new technology, but it's got clearance from the FDA, and the American College of Cardiology Foundation has invested in it. So I went and I had one, and I paid for it myself to be completely objective, and it was really very interesting. They basically put you in the scanner, and they give you this IV injection of an iodine-containing contrast substance, which is it's completely painless, but a little freaky. It's very warm, and it makes you feel like you peed yourself when it goes into your femoral arteries. But in the end, you get this incredibly full, detailed analysis. And I thought it would just be super interesting to do a podcast on this for you all and just go through it. And I was able to sit down with Anita Vadria, who is the Director of Medical Science, Liaisons, and Clinical Education at Cleerly. She's a board-certified physician assistant with a focus in cardiology, and we just sit down and we explain the basics of coronary artery calcium and plaques and the different kind of plaques and what Cleerly does, and then we go over my scores. And being a journalist for 30 years, I also, of course, wanted to have an independent expert weigh in. So I dropped a line to Dr. Martha Gulati, president of the American Society for Preventative Cardiology, who has been on the show. And I got her 2 cents on the technology. And she said she thinks this technology is helping doctors to refine risk. And she mentioned that there's a large ongoing trial that will help them see if this next layer of information that Cleerly gives translates to better health outcomes. Like, does it prevent heart attacks and strokes? Because that's what we're going for, right? And I asked her if there were benefits for women specifically. And she said that though there isn't anything sex specific about Cleerly per se, that there is an issue that the traditional risk assessments, as I mentioned, underestimate risk in younger women. So having tools like this can help refine risk in clinical practice. And there were also some studies that came out last year and earlier this year showing it's pretty useful. So I'll drop those in the show notes as well. I want to be clear that I'm not doing this show to say everyone should run out and get this done. But I do think if you're concerned and you're thinking about getting your arteries checked, it's just like a really interesting thing to be aware of. Okay, so I have talked an awful lot here. I really wanted to just set this up. And I hope you enjoy this conversation as much as I did. I think all of this is incredibly interesting, and I wish we were 10 years in the future, but we're not. So this is where we are, and we have to take from it what we can. All right. Enough of me. I just want to say a very quick thanks to the sponsors of the show. Thank you to Foci Optics for being a supporter, for making this happen. If you're looking for some high quality, reasonably priced sports shades or casual sunnies, Tifosi has you covered. And that is truly enough of me for this intro. Let's have a few words about our awesome sponsors and get on with the show. Okay, Anita, I am so glad to have you here today because this is a conversation, honestly, and a topic that I have been following for a very long time as both a health and science journalist and also as I was a semi-professional mountain bike racer, and I wrote for bicycling and men's health and women's health, and this would always come up about coronary artery calcium and this specter of maybe it's a problem for very highly active people, and then I got into the menopause space and I'm like, oh, it's a big, it's a big topic of conversation there too. And now they're sort of intersecting that I'm talking to very active menopausal women. So it's a very long-winded way of saying thank you for being here and talking about all this.
It's my pleasure. I'm really excited to be here, Selene. Thank you for having me.
So let's start with just opening up the discussion on plaques, especially for this audience that is highly active. I've shared with you before our conversation that I've seen evidence suggesting that masters athletes, at least men specifically, tend to have these higher coronary artery calcium scores, which seems paradoxical. But then there's like this research that's like, okay, they do, but is it a problem? And we don't know. And then I would go into JAMA and there's research that maybe it's not a problem for women, but then menopause. So can you talk kind of broadly about this?
Yeah, absolutely. So, when I think about the connection between athleticism and plaque, I think to your point, I think it's very multifaceted. I think it's very intrinsic. It's very intricate. And there's a lot of research to suggest that high intensity exercise, particularly endurance sports such as marathon running or long distance cycling, can lead to an increase in oxidative stress and inflammation. And from what we know, that those things can contribute to the development of plaque in coronary arteries. Now, I think it's really important to note that while coronary plaques are more abundant in athletes, the plaques that are there tend to be more stable in nature. And what I mean by that is that from what we understand about plaque is that all plaques look and behave very differently. So calcified plaques are the type of plaques that are more prevalent among athletes. And they're generally considered the least risky type of plaque. They pose the lowest threat of triggering a heart attack compared to something called non-calcified plaques, which are
Hmm.
soft plaques. And so I think this is one of the reasons that Cleerly was developed to not only detect atherosclerosis or the presence of plaque, but also discerning their composition, so their makeup, to really understand if it's calcified plaque or if it's soft plaque and how that truly influences a patient's risk.
That's a great description, and thank you for that. And I actually, right before this conversation, a study dropped on my desk on men and women and showing that it doesn't, that even, I think there was like 3,000 mets of exercise a week or more, which is, an hour of running a day or something, did not accelerate those plaques in either men or women. So I thought that was really interesting. I think that was maybe in JAMA Open Network. I can't remember, but I'll drop that in the show notes. So I thought that was interesting.
Yeah, yeah, I agree. I think there's a lot of I think our understanding of it is definitely evolving. I think there's a lot of research happening in the space of athleticism and how it affects coronary plaques. When we think about, I think there's definitely a difference when we think about the degree of plaque buildup in men versus women.
I was just going to ask that. Yep.
Yeah, yeah. There's a lot of research. And in general, what we find, Celine, is that plaque volumes for women tend to be about 10 years behind that of men. And so, for example, a 60-year-old woman has about the same amount of plaque on average as a 50-year-old man, due to, of course, physiological differences between men and women, but hormonal influences as well. And so, we know and evidence suggests that estrogen plays a really important role in maintaining bone density and has protective effects against plaque buildup. So women, of course, typically have higher levels of estrogen, which could contribute to lesser calcium depositions and plaque buildup compared to men. I do think it's important to kind of note these individual differences. They do override these general assumptions in the research. But I think, again, research is ongoing and our understanding of this continues to evolve.
Yeah, it's interesting. I mean, that continues to evolve on the daily almost in my world. I see so many things coming out about the acceleration of some of these risk factors post-menopause, right?
Yeah.
And, the coronary um, artery calcium seems to be one of those. Do we, and this might be outside of the scope of what you can talk about, and that's fine, but have you seen where hormone therapy enters this conversation?
So, we do know that there are physicians that do rely on hormone therapy. I can speak to, what we do know for a fact is that menopause does indeed influence plaque buildup in women, right? It's
Yeah,
been
yeah,
shown that estrogen does play a very significant role in maintaining cardiovascular health.
yeah.
So, of course, when estrogen levels decrease, there can be changes in lipid metabolism, inflammation, and both of these do contribute to the development of plaque. I think women kind of transitioning through menopause, I think should really prioritize cardiovascular health, of course, by adopting, heart healthy habits. But I think it's also important to have a conversation with your physician about how you can be proactive about your cardiovascular health. Just like, I think when you have the information that you get from a Cleerly analysis, you have that specific information in terms of what your heart health looks like. So how much plaque do you have? But more importantly, what type of plaque do you have and how you can really kind of get ahead of it and kind of treat it and be proactive when it comes to your heart health. So I think it's a great opportunity to kind of have that conversation with your physician and see, what are the best steps that you can take from a primary prevention perspective to kind of lower your risk as you kind of go through menopause, because we know that, cardiovascular risk does go up. And now we have these tools, in the toolbox to be able to use these tools to really kind of help lower that risk.
Can you talk a bit before we get there about the connection between cholesterol and these plaques? And, we talked a bit when we were talking about the athletic population about the calcified and, the stable, but I'd like to talk a bit more about that, like how plaque gets
Yeah.
laid down, what role cholesterol plays or doesn't play in that? You have the different kinds of cholesterol, like really setting that
Yeah.
picture.
Yeah, so it's a great question, Selene. So, from what we understand about plaque, and of course, as what research suggests, is that plaques look and behave very differently, and because of that, their risk is also very different. So, when we think about coronary plaques, they're divided into three categories. There's calcified plaque, there's non-calcified plaque, and there's something called low-density non-calcified plaque. Now, they're classified in these three categories based off of their composition, so what they're made up of. So low density non-calcified plaques are made up of fat and cholesterol, and they're often the most dangerous form of plaque. They have the highest likelihood of rupturing due to their makeup. They're just a very unstable form of plaque. Now, when a plaque ruptures, it can instantaneously lead to a blood clot, and that blood clot is what leads to the blockage, and that blockage leads to the restriction in blood flow, and that's what leads to a heart attack. And unfortunately, in some cases, it leads to death. Now, when we think about non-calcified plaques are not as prone to rupture as low density non-calcified plaques, but they still have some risk because they're soft plaques. So if left untreated, they can pose some risk. Now, lastly, when we think about calcified plaques are the least likely to rupture. They're the most stable form of plaque. They're relatively the most benign form of plaque.
Gotcha.
Now, our understanding of what causes a heart attack has also evolved over time. So initially, we thought calcified plaques, or as a field, we thought calcified plaques were considered the primary concern. However, as research has progressed, it's become really evident that it's not just the presence of plaques that pose the risk, but rather the composition and the stability of those plaques. So, these advances in imaging techniques, such as Cleerly, have, really allowed physicians to better visualize and characterize these plaques to have a deeper understanding of a patient's true risk. And I want to touch on your question about cholesterol,
Yep, I
right?
was just gonna ask that. Yep.
The historical approach to heart disease evaluation misses too many people, right? Like you, myself, I'm sure everyone listening to this podcast knows someone who is in great shape, unfortunately had a heart attack, right? Kind of came out of nowhere. And that's because half of the people who suffer from a heart attack show no symptoms of a heart attack. So no chest pain, nor shortness of breath. And about 70% of patients who end up having their first heart attack are also considered low risk, meaning they don't have elevated cholesterol, they don't have a family history, their BMI is it's not high. So we know that risk factors are not the ideal biomarkers to identify those at risk. Of course, I think it's great for population comparisons, but on an individual perspective, we know that there isn't a direct correlation between elevated LDL or elevated triglycerides and having a heart attack. There's definitely a relationship there, but it's not 100% linear by any means. So I think, while it's important to kind of focus on those biomarkers, right? It's good to know what your cholesterol is. We want to obviously optimize your cholesterol. I think it's equally important, if not more important, to be able to have an individualized assessment of what heart health truly looks like.
Yeah, I've done a whole show and written about that, especially given the light that we're now seeing about how the risk calculators very much undercalculate women.
Mhm.
Because they don't take into account myriad things, including what was blood pressure during pregnancy, like what did like there's a lot of factors that they just don't even account for, and that our bars aren't the same place as men, sort of you alluded to before. How does cholesterol lay down plaque in our arteries? On a very basic question.
Yeah, no, I think it's a great question. So, when we think about atherosclerotic plaque, right? Atherosclerotic plaque is made up of cholesterol. So it's
Yep.
made up of cholesterol and fat and blood cells and other substances that kind of build up in the inner lining of the arteries. And that's what leads to the arteries to thicken and harden. And ultimately, what happens is that plaque starts to encroach inwards. And once it does that, it starts to form a blockage. And so that's kind of one aspect of what we see that leads to a heart attack. But in most instances, what we see, Celine, is that um, a heart attack is not usually caused by the 80–90% narrowings that we see in the coronary vessels. It's really caused by that high risk plaque that I was mentioning earlier, that low density non-calcified plaque, that really unstable form of plaque that's filled with cholesterol, that ruptures. And when it ruptures, it instantaneously forms a blood clot when it's exposed to the blood. And
Hmm.
then that completely occludes or blocks the artery. And then that's what leads to the heart attack.
So if and just following this down the line, because we hear that high cholesterol leads to plaques. Is that
Mhm.
something that we always see, or what is the
Yeah, we don't always see that, Selene. So what we end up seeing is that when you look at historical data, right, 70% of patients who end up having a heart attack will have normal cholesterol. They'll have a
okay,
normal LDL, they'll have normal triglycerides. So it's not always correlated to elevated cholesterol.
right. Is
And that's why we
ApoB
hear
a
about,
magic number?
I'm sorry.
ApoB, is that the magic number that, I mean,
Yeah, there's a lot of research that's going on to kind of look at the effects of ApoB, LP little a.
yep,
Clearly, as a company, is also doing some research, trying to put some studies together to kind of see the effect of LP little a as well as ApoB and how it impacts the development of plaque, more importantly, soft plaque, so low density non-calcified plaque. Are we finding that women and men who have higher levels of LP little a or ApoB, do they develop more low density non-calcified plaque as well as non-calcified plaque? And
gotcha.
I think the answer is yes.
Interesting. Okay, great. So when you talk about the scans, often people will have their doctor recommend either a CACS or a CCTA. There's very simple scans, and then there's like more nuanced scans that include some contrast dyes. Can you
Yeah.
talk through the basic scans that somebody might be referred to and like what they're looking at?
Yes, absolutely. I think it's a great question. So there's something called the CCTA,
Yep.
which stands for a coronary computed tomography angiography.
Yep.
And it's a non-invasive imaging test that's used to visualize the coronary arteries. So it helps to detect blockages or narrowings or other abnormalities that could lead to a heart attack. Now, it's a very valuable tool. It's a very valuable imaging modality due to its non-invasive nature, its very high accuracy, and its ability to provide detailed images of the coronary arteries. The societal guidelines, so the American College of Cardiology, as well as the American Heart Association, they've endorsed CCTA as a first-line test of choice for evaluating a large portion of patients with coronary artery disease.
Okay.
Now, a Cleerly analysis uses advanced imaging from a CCTA with machine learning to non-invasively analyze the images for atherosclerosis, so plaque, as well as stenosis, so areas of narrowing. So that's what a CCTA is. Now, the second test that I think you mentioned was a coronary artery calcium score. Now, there's
Yep.
some distinct differences between that and a CCTA that I wanted to highlight. So,
Yep.
coronary artery calcium score also images the heart with CT, but it only measures the amount of calcium in the heart's arteries. So it only measures one type of plaque, which is calcified plaque.
Okay.
And as we discussed earlier, there's other types of plaques that are more important, right? So the non-calcified plaque, the low density non-calcified plaque. So really with the coronary artery calcium score, you're not really getting the full picture. You're only getting information on calcified plaque, and you're not getting information on the soft plaque, which is really what we're most concerned about. So a CCTA with Cleerly is different because it provides, a more comprehensive report. It shows the various types of plaques. It gives the specific amount of plaque, and the distinctions between high risk and low risk plaques.
So talk to me about what clearly enabled CCTA scans actually are and how that works.
Yeah, absolutely. So again, Cleerly uses these images from a CCTA with our machine learned algorithm to non-invasively analyze for atherosclerosis, for the buildup of plaque, in
Yep.
areas of stenosis or narrowing. So our software generates a 3D model of the patient's coronary arteries. It locates and it quantifies areas of narrowing, so any stenosis, as well as identifying, quantifying, and characterizing the plaque. Now, this approach, it's been grounded in very strong evidence from over, I think it's over 10 million images with over 40,000 patients over 15 years. So we've had various multi-center clinical trials that have really validated clearly as one of the most accurate approaches with superior accuracy to not only identify, but characterize plaque as well as stenosis.
And I will never understand exactly how it does that. So I could probably ask that question many ways, but it is using, is it some sort of AI? Is that what we're talking about?
Yeah, so it's basically AI as well as a machine learn algorithm that
Okay.
takes images from the CCTA, and we're able to apply our software on those images. And from that, we're able to precisely identify plaque all the way down to specific cubic millimeters. So from our analysis, we can give information to the patient as well as the physician in terms of how much plaque was found among all of the coronary vessels, how much
Okay.
of that was calcified, how much of that was soft plaque, to kind of be able to understand a patient's true risk.
Gotcha. So I had this done, which we can certainly talk about. It was interesting. And I have to say, one of the things that we need to change in our general system. I mean, so many people are like, "Why are you here? Why are you here? What are you doing here?" Because I'm not their classic like patient.
Mhm.
I'm being proactive, and I'm just like, well, I'm being proactive. And I get looked at like I've got 12 heads. And I'm just like, I mean, I feel like that's
Yeah,
just my soapbox statement for the podcast today. Um, but yeah, I had it done. And do you have my results?
I do.
Okay.
I do. Yeah. I'm happy to kind of go talk to you a little bit about that. So first of all, thanks for your willingness to share that with us and the audience, about your personal health and your experience with Clearly. So, of course, I think each patient has their own experience, their own unique experiences, but I think it's safe to say that with you getting a Clearly analysis, I think you learned a lot about your heart health. Um, of course, I won't get into any recommendations around treatment or management since that's a conversation for
Yeah.
you, the physician who ordered the Clearly analysis. But I can share at a high level what was found on your analysis. And I think, importantly, kind of highlight the importance of what this information means to determine your true risk.
Okay.
So Clearly, so we're a decision support tool that allows the patient and their physician to determine the amount and type of plaque that a
Yep.
patient has, along with any areas of stenosis, as well as the functional significance of that stenosis. So what that means is that stenosis causing an insufficient amount of blood to reach to the heart?
Yep.
And so when we looked at your analysis, Selene, you had 86.2 cubic millimeters of plaque. Now that's the total amount of plaque that was found among all of your coronary vessels. Now we see anywhere from 0 to 3,000 cubic millimeters of plaque. So it's safe to say that you're definitely on the low end of that range at 86.2 cubic millimeters. Now, when we look at that number, the software provides that specific cubic millimeters, but it also provides something called a percent atheroma volume. Now, this is a calculation that's done by the software that takes your individual plaque volume in cubic millimeters and it divides it by your individual vessel volume.
Okay.
And it multiplies that number by 100 and it provides a percentage. And that's
Okay.
called a percent atheroma volume. So your percent atheroma volume was 1.6%.
Okay.
So another way to think about it is about 1.6% of your total vessel volume was occupied by plaque. And I think, Selene, I think you'll really appreciate this. I think one of the key features of a percent atheroma volume is that it provides a more individualized measure of plaque burden in addition to cubic millimeters. And it takes into account gender differences
Mm-hmm.
because it's looking at your specific vessel volume, right? We know women have smaller vessels than men.
Right. Right.
So 600 cubic millimeters of plaque can mean very different in a woman than it does in a man, right?
Right.
And
Right.
so I think it's very important to take that percent atheroma volume into account when we're thinking about risk. So when we look at the 86.2 cubic millimeters of plaque, we're able to differentiate that plaque between calcified plaque and non-calcified plaque. So of the 86.2 cubic millimeters, it's safe to say that the majority of your plaque was calcified at about 51.7 cubic millimeters.
Okay.
Now, the remaining 34.5 was non-calcified plaque, so it was soft plaque. But the good news here is that you did not have any low density non-calcified plaques. If you recall, that's that necrotic core plaque, that very high risk plaque, and you didn't have any on the analysis. So I think that's a huge positive. You did have some soft plaque, but the majority of your plaque burden is calcified at 51.7 cubic millimeters. And so that's kind of what we saw in terms of plaque. Now, looking
Yep.
at areas of stenosis
Okay.
uh, or areas of narrowing, you had two very, very minimal stenosis. You had a little 4% stenosis in the proximal LAD, followed by a 6% stenosis in the first diagonal. So very, very minimal disease. So I think these are all very, this is all very positive for you, Selene.
I appreciate that. Yeah, I mean, it was really, really interesting to go through it, and obviously I went through it, with a doctor and all of that. And it's enlightening, especially for me, having been and still, I'm riding 110 miles this weekend, one
Yeah.
day. Like I still do this stuff, and I have had borderline high cholesterol my entire adult life. I have very high HDL. I also have, so the whole number has been high, and my doctor's always been like, "Yeah, your triglycerides are really low, your blood pressure is low, like everything else looks good, so we've just let it ride."
Mhm.
And it was just nice to get this to be like, "Okay, I'm 55, and post menopause, what does it look like
Right.
in there?" You know?
And I think the beauty of it, Celine, is it kind of gives you a baseline, right? And
Yeah.
so, I think, with the Clearly analysis, the software also has the ability we have something called the compare feature in the software. And what I mean by that is if you do a Clearly analysis, let's say on day one, and then you do another Clearly analysis, we can actually link the studies in the software to be able to compare them side by side. So when you get, if you do another Clearly
Mhm.
analysis, we can actually link them and kind of see the differences in plaque volume. So I think, success for you would be if your plaque volume stays at 86.2 cubic millimeters, or hopefully it goes down, and you don't develop any low density non-calcified plaque, and your non-calcified plaque volumes goes down, and your calcified plaque volume may go up, and that's okay, right? Because we know over time our body naturally calcifies plaque.
Right.
Of course,
Right.
there's medications, there's about 5 or 10 medications now in the toolbox that have shown in clinical trials to really have a favorable effect on plaque and kind of help accelerate that transformation process of taking the soft plaque and converting it to calcified plaque. But now, in the software, we can actually link these studies and be able to compare them side by side. So your physician has the ability to disease track, if you will.
So you said something, I'm gonna ask a very naive question. You mentioned, um, the plaque going down. How would does I don't think I knew that could happen.
Yeah, yeah. So that's called plaque regression. And so what we've found is that for the most part, we see plaque transformation or plaque stabilization, where
Yeah.
that soft
Yeah.
plaque is converted to calcified plaque. But we've seen in some instances, and this is anecdotal experiences, when we kind of do these case reviews and when we speak to physicians, what we find is in some cases with being on certain medications such as PCSK9 inhibitors and lifestyle interventions, what we see is that in some instances we've seen a regression in plaque volume. So we've
Hmm.
seen a reduction in total plaque volume. I will say it doesn't happen as often as the transformation or the stabilization, but
Okay.
yes, we've definitely seen instances where there is a reduction in total plaque volume.
Good to know. So, and then finally, we should talk about, I think this is all very exciting, technology. I also want to be mindful that it is not necessarily available to every single person right now. Can you talk a little bit about where we are with this as far as, insurance, because these things cost money, for people who might want to take this step, what do they need to know now as far as like where Clearly is, where it's going?
Yeah, absolutely. So Clearly it is now reimbursed by insurance. However, the extent of coverage kind of varies dependent on your plan, your insurance company, where you live. So if any of your listeners are interested in getting more information on how to get a Clearly analysis, as well as insurance coverage specifics, they can go to our website. It's Clearly Health, and Clearly is with two E's. And from there, they can contact us, and someone from our team will be in touch with them to kind of get them the information that they need. We have an entire team dedicated to help patients kind of get the resources that they need to be able to get the Clearly analysis.
I'll put that in the show notes for people to make it easy. Um, is there anything that we have not talked about that you wanted to make sure that people understood about any of these issues that we've covered today?
Yeah, the only thing I really wanted to emphasize is that, you know, now that we have the ability to identify this disease, identify coronary artery disease early, I think the good news here is that there's a lot that can be done to intervene and to early to be able to lower your risk or lower anyone's risk of having a future heart attack. So I think when a physician and a patient, they have access to the information from a Clearly analysis, the physician can really make an individualized treatment plan that can include lifestyle interventions, medications, a lot of things can be done. There was a paper that was published in a very well-known journal called the American Journal of Medicine,
Hmm.
uh, which published something called the atherosclerosis treatment algorithms. And they've been developed for physicians to be able to kind of integrate all of this information from Clearly to be able to provide a personalized treatment plan for patients. So I just wanted to kind of reiterate that, we now that we have a way to identify disease early and to be proactive, I think it's great because we have the ability to kind of intervene early and really truly change the trajectory of patients.
So that I'm very, very curious if there is or will be because hormone therapy is like the conversation right now, and and there's still a lot of argument about how much it does or does not influence cardiovascular disease outcomes, right? Like the big WHI study just came out, was still not recommending it for primary prevention, but you have some studies suggesting that used in certain people in a certain period of time in a certain population, that yes, it does reduce this. It seems to me that there's an opportunity here if you're taking that kind of information on the intake of someone like myself or other women who are telling you, yes, I am, no, I'm not. Couldn't we at some point get a picture of like what a hormone therapy might have on this kind of disease process? I mean, in a study context. I mean, is Clearly involved in anything like that?
Yeah, so as of right now, we're not really involved in anything to kind of around hormone therapy. But to your point, I know there's so much research. I read it myself, and I think it's definitely evolving, right? Because I think there's different thought processes when it comes to hormone therapy. Is it effective? Is it not? How does it affect atherosclerotic plaque? Is it affecting the calcified plaque? Is it affecting the soft plaque? So I think, hopefully soon we're gonna have a lot more clarity on that. But again, I think there's a lot on the table in terms of things that we can do to kind of mitigate that risk. And I
Yeah.
think hormone therapy may be one of those things.
Yeah, and we're only gonna get more information,
Yeah.
right? We're only gonna get more information down the road. Uh, yeah, thank you so much, Anita, for this. It's really, really interesting and very insightful. And I think this is all gonna be a great this is all part of this great sort of medicine next step, right? The precision medicine and really taking care of individuals, which is what we should be doing.
Yeah, absolutely. Thank you, Selene. I really appreciate the opportunity to have a chance to speak to your audience and share all the great things that we're doing here at Clearly. I really appreciate it.
Right. Thanks so much. I'm gonna just stop. Well, that's our show. Come on back next week when I sit down with Kristen Arnold of Sports Nutrition for Women. We sit down and have a great chat about all the best sports supplements for midlife and menopausal women specifically. So you won't want to miss that one. So come on back next week. And until then, as always, stay feisty. You've been listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I'm your host, Selene Yeager. The show is edited and produced by the strong, talented, and amazing women at Live Feisty Media. Follow us on social media at Feisty Menopause, and please help us spread the word. Screenshot and share this episode on your social media channels with the tag @FeistyMenopause. Share the show with your friends, and please subscribe, like, review, and rate this show wherever you get your podcasts. Word of mouth and good reviews make it easier for other listeners to find. Thanks for listening, and as always, stay feisty.